Share my screen. There you go. All right. So welcome to week number 6. We're going to talk about opioid use disorder today, and we're probably going to touch on alcohol also. All right. So this is just the pathways. I know last time that some of you were confused about the pathways, the dopamine pathways. They all kind of like link together. So serotonin obviously interacts with dopamine, dopamine interacts with serotonin. It is a little complicated, which is why sometimes when you give someone a medication, it's hard to know how they're going to react to it. But just having an understanding of how the brain works anatomically and functionally will give you a good understanding. All right. Think of like the cortex, which is the big part of your brain, as kind of like a way to stop people from having impulsive behaviors, right? So obviously, when someone's doing therapy and the therapist is talking to them about what their triggers are and some ways to kind of help calm down their hyperactive limbic. So your limbic system, you can think of that like your brain that wants pleasure all the time, right? So if someone has a predisposition to alcohol use disorder or opioid use disorder, right, their ventral tegmental area might be very sensitive. Once you hit it with a little bit of dopamine, it wants it again, right? So remember the pathways in the very beginning. You have the what? You have the ventral striatum, right, which has to do with impulse behaviors, right? You go to a party, someone says, hey, try this. And you're like, you know what? I'm feeling good today. Let me try it, right? Whatever it is, whatever substance it could be, right? It feels good. It hits that reward pathway, which is the mesolimbic pathway. So that's the ventral tegmental area, which innervates the nucleus accumbens or the ventral striatum, all right? That pathway feels good. It kind of reinforces it, right? Your opioid receptors are hit. That's the pleasure pathway. And all of a sudden you do it again, right? You do it a certain amount of times. So what happens? It moves from the ventral striatum to the what part? Which striatum? The dorsal striatum, all right? So dorsal striatum has to do with movement, all right? How I remembered it, it's a little dirty, but if you can remember DS, doggy style. You can't do doggy style unless you're moving, all right? Dorsal striatum. That makes sense. Now you never forget it, all right? Dorsal striatum has to do with movement. So if someone has an issue with, I don't know, balance, gait, stiffness, no, that pathway in dorsal striatum is not getting enough dopamine, right? You're giving someone a dopamine blocker like Haldol or olanzapine, like we talked before, and then that's going to affect. Remember, the brain doesn't really know where the meds are going to go, right? It's pretty permeable once it gets inside, once it's fat soluble. So it's going to affect all your dopamine pathways, right? So if it hits too much of the mesocortical area, what's going to happen? What are you going to see with the patient? Cognitive dulling, maybe, right? Issues with concentration, issues with focusing, right? It hits the dorsal striatum, hits that pathway, which is the nigrostriatal pathway. What happens? You start having Parkinsonism, right? Stiffness. You might notice that as abnormal arm movement. Maybe they might have some Parkinsonism, which is tremors, right? Mask-like facies. So, learn how to distinguish what's happening. Is it drug-induced Parkinsonism or is it Parkinsonism that's happening naturally? How can you tell that? Well, this isn't always correct, but sometimes you can kind of tell what's drug-induced Parkinsonism versus Parkinsonism that's primary. How would you know? Tremors. Would you see bilateral tremors with drug-induced Parkinsonism, or would you see one side, unilateral tremors with drug-induced Parkinsonism? What do you think? Considering what I just told you about medication, where the brain can distinguish where it's going to go. Think it's be bilateral or unilateral, the tremors.
Doesn't Parkinson's usually affect just one side or primarily one
Usually,
side?
usually, yeah, depending on where the lesion is, right? So it could be, your right side of your brain, which is going to affect your left side, right? Or it could be in the left side of your brain, which is affecting your right side. But like I mentioned, since when you take medication and it's blocking dopamine pathways in both sides, usually it's bilateral, right? You'll see both sides. They'll have tremors on both sides usually, right? They'll have stiffness on both sides, right? And people can have both, right? They can have Parkinsonism that's usually unilateral. Then you give them a D2 blocker because they have schizophrenia at the same time. Then of course it's gonna affect both, right? Okay. So this is kind of like how the mesolimbic pathway is innervated by different substances, right? So nicotine, you have nicotinic receptors on the VTA. Remember, just know the mesolimbic pathway is the pathway for psychosis, for mania, and also the pathway that's, due to addictions, right? You hit that pathway sometimes, people feel good. You hit it too much and they become psychotic, right? They get euphoric. About what happened to you, Robert, that patient, what happening is when they're taking opioids, what happens, your receptors become what? When you're hitting opioids, right? And opioids kind of depress stuff, your receptors are gonna upregulate, right? So when you remove that, you can have a hyperactivity, right? So that's same with alcohol also. People can have alcohol withdrawal and they have something called what? alcoholic hallucinosis. Have you ever seen that? Alcoholic hallucinosis? It's
Um,
not DTs yet. They're not having seizures, but it could be a precursor for it, right? They can have psychosis. And a lot of times they'll have visual hallucinations, actually. Sometimes you'll see little people. They'll tell you, hey, I was in the hospital and I was seeing midgets, right? Or little people running around. So visual hallucinations could be withdrawal, right? So if you look at this chart, I mean, it looks pretty simple, but it kind of breaks down how does a GABAergic VTA interneuron that, a lot of times can be innervated by different receptors, right? So alcohol, cannabinoids, opiates, it all hits that mesolimbic pathway. I'm not going to test you specifically on this because I want you guys to understand the clinical aspect of it, but just know how the brain reacts can give you certain, symptoms, right? Let's talk about opioid use disorder. So what happens if someone is intoxicated? We'll go with intoxication first, right? You hit the mu opioid receptor, and what are you going to see clinically with a patient? What's going to happen to them?
uh, Pupil constriction, respiratory depression,
Yes,
sedation.
sedation, right? Okay, and there's also antidepressant effects actually, right? There's certain mu opioid receptors, like so you have three opioid receptors. You guys know them? There's the mu, which everyone knows. What's the other one? Kappa.
Kappa.
Delta and the kappa.
Yep. Yep. Mu kappa delta. All right. There's actually some antidepressants now that are working on kappa, because they realize that innervation of those receptors also have antidepressant effects. So sometimes people might be self-medicating, right? They're using opioids because they might have an underlying depression, and that's the reason why you want to treat it, right? Let's stop the opioids because maybe an antidepressant might be safer for you, all right? Because you're not going to have the risk of respiratory depression, all right? What's a dangerous combination? Someone who's using opioids and what?
Benzos.
Benzos, right, or alcohol, because it kind of gives a synergistic effect, right? They feel better, and it's at the same time it can increase the risk of respiratory depression. All right. Any questions so far? So this is just the way alcohol affects it, right? So arcuate nucleus is also mediated by opioids. You know that the opioid receptors mediate pleasure, all right? And the dopamine kind of mediates reward-seeking behaviors, all right? So they're linked together, but sometimes you have to understand that distinction, because if you want to stop someone from doing something and they're chasing it, do you think you want to affect opioids or do you want to affect dopamine? Someone's looking forward to something and they want to get it, they're looking forward to it. It's more reward-seeking behavior. What would you want to modulate, dopamine or opioid receptors? What do you think?
Dopamine.
Dopamine, right? And sometimes that's why there's a lot of studies now with partial agonists. There's actually studies now with partial agonists because remember, what did I say? In the presence of too much dopamine, a partial agonist works as a net antagonist, right? When there's not enough dopamine, a partial agonist works as an agonist. So you kind of stabilize that. Similar to how does varenicline work in nicotinic receptors, right? When you're smoking cigarettes. Why does it help with cravings? Why do you think? Because you're giving someone just enough nicotine. It's a partial agonist of nicotinic receptors, right? You're giving someone just enough nicotine, just enough acetylcholine that they're not going to have that craving from the withdrawal. Similar to for opioids. I don't know, you tell me. What's a partial agonist opioid receptor that helps with cravings? People know.
Buprenorphine.
Yeah, buprenorphine, right? What's the difference between buprenorphine and Suboxone? Rob, I know you know the answer for all this, so let them have a chance.
Okay, I'll let other people answer.
Yeah.
The Suboxone has
Right.
naloxone or naltrexone.
You tell
Naloxone.
me, what's the difference between naloxone and
Naloxone. I
naltrexone?
think
Very
it's
good.
naloxone.
What's the difference between naloxone and naltrexone? What's the difference?
Uh, I think one has a shorter half-life. The naloxone has a shorter half-life.
Okay, besides that, yeah, rapid onset, right? So if you give someone naltrexone, right, it works longer. It doesn't peak as quickly. So you're not going to use naltrexone as a rescue drug, right? If someone's like intoxicated, they're not breathing, you're not going to give them naltrexone. You're going to give them naloxone. All right. So if someone is Suboxone, does the naloxone work at the same time that the buprenorphine works or no?
No.
All right. What about if someone tries to use it another way? Someone tries to like melt it and inject it, or someone tries to use it the way it wasn't supposed to. What happens? The
I think
naloxone
that's when the
very
naloxone
good,
kicks
right?
in.
So that's kind of like the safety profile of Suboxone, right? Do you guys, Rob? Do you guys always use Suboxone? Do you guys use Subutex also, the one that doesn't have naloxone?
At this place, at the place I work, we only use Suboxone, and we have a new CMO. I just convinced him to start a Sublocade program.
Oh, you
because
told me about that. Yeah.
I keep having to refer people out, and it's actually like a pain in the butt to find Sublocade in New York City. Kings County is like the only place I know that I can send people.
Yeah. Oh, interesting. Okay.
Yeah, but we just started now, so I'm looking forward to it.
Do you want to tell the class a little bit about Sublocade? What do you know about it?
Yeah, so Sublocade, we usually once you're stable on Suboxone, and you have to be. A lot of people don't like Suboxone, so you can't jump into it. So you have to get somebody. I like to have somebody on Suboxone films for 2 weeks, uh, at least, and then once we have them stable on that, they can do a monthly injection. This is like especially valuable in where I work because I work in an outpatient treatment facility that also does methadone. So this place is strict. You know, you can't just go to CVS and get Suboxone because the state makes us make people jump through all these hoops. Because of that, if you don't want to come to this program, you know, multiple times a week or once every 28 days, you can get an injection every 28 days. Um, and it's great because, you know, Suboxone has a higher affinity for the opioid receptor than, or I should say buprenorphine does, than other drugs. So once you're stable on it, even if you use heroin, you're just wasting your money, um, which is good times. You know, buprenorphine's the best.
What's your view about at-home inductions?
I love it. It's like my way to do it.
Really? Okay.
Yeah, it was impossible for us. Like actually, hold on. Let me grab my at-home induction packet here.
So can you talk us through that? Because I don't have experience doing at-home inductions. How do you do it with a patient? I'm just curious.
Yeah, so it starts pretty much with a pep talk where you have to explain to the patient what's going on and what
Can you role play with me a little bit? This is a good learning experience. Pretend
yeah.
I'm a patient. All right.
So I tell people that you
No,
need
no,
to
but role play with me. Talk to me. I'm gonna be a patient. All right. Are you ready?
okay, I have to suspend my disbelief then. It's kind of hard for me sometimes. Okay,
Hey
so
Robert, I really want to get off my heroin, and I don't have time to sit in the office for 2 hours to do the inductions with you. And I heard about at-home inductions. Is that something I could do?
yeah, at-home induction is definitely something I can help you with. I think that that's actually the best way to do this.
What's
When
good
you
about it? Well, why is it better than in the office for me?
Well, starting Suboxone, you have to think of it as going for a small procedure or something. You're going to be off your feet for a couple days, most likely. Suboxone is very easy on day 3 or 4, but it's not so easy on day 1 or day 2.
I mean, I don't want to shit my pants though. My roommate's gonna be there.
Yeah.
Is that
Well,
gonna happen?
you know, it could happen, and I'll talk you through what to do. I also have a list of medications that I'm going to give you, and one of them on here is going to be loperamide. Loperamide, you might have seen it in the drugstore, is Imodium. What people don't know about loperamide is actually an opioid, but it doesn't cross the blood-brain barrier. It works in the gut, and it will prevent you from, or will alleviate some, the diarrhea, the stomach cramps, the things that you usually feel when you're in withdrawal. Um, I'm going to give you all these medications and this guide of when you should use what.
What about for my anxiety? Should I just take the Xanax that I bought off the street for my anxiety if I get anxious when I'm withdrawing?
So not one off the street, because at least here in Harlem, that stuff is fentanyl half the time,
Yeah.
and it's just
Can you
fake.
prescribe me Xanax?
No. There are some clinicians who might think that that's appropriate, but I prefer to use medications like clonidine and hydroxyzine to manage anxiety, cravings.
What's the difference? Why would I use one over the other? I'm just curious.
So I think that hydroxyzine can be useful. I mean, they can both be useful for people with insomnia. If you're having a hard time, if you're restless at night, withdrawal. Hydroxyzine probably more than clonidine for that. Clonidine has been demonstrated in studies to reduce cravings for opioids. It can also reduce some of like the agitation and the restlessness you feel. So I think that clonidine is a very safe medication for most people. You could take it. I'm going to give you a low dose. You could take it 4 times a day if you need to, and you really will probably only need it for these first 2 days.
So how much Suboxone am I gonna come home with in the first day?
So that depends on how much heroin you do. But I like to make sure that people have enough. Also, the literature is evolving on this. It used to be that everyone had an 8 milligram Suboxone induction. This day and age, that does not work for most people. That might work for someone who's taking oxycodone or Percocet, and that's their opioid dependence. But for someone who's snorting or injecting fentanyl, which is highly lipophilic, and people, it has a short duration of action, people go into withdrawal quickly, they develop a high tolerance. Those people tend to need higher doses.
What's the highest that can go? How much Suboxone can I go home with tonight?
So yeah, the highest that I think that most people 16 milligrams will probably do the trick. Some people will need 24. Insurance won't pay for 32, and the data does not necessarily support the use of 32 milligrams. But if there's a time to do it, it's in the first couple days.
How long do I have to be sober? Do I have to be off the heroin before I start the Suboxone or?
So the sheet I'm going to give you, I have two versions of it. One is from a long-acting medicine like methadone, and then or fentanyl.
I've never been on methadone actually. I've just been using heroin.
Oh, okay, not even on the street. Most of my patients have at least tried it on the street. Yeah,
No, I haven't tried it. No.
yeah. So from a long-acting medicine, I would recommend taking little doses of Suboxone and going slow. From a short-acting medicine like oxycodone, immediate release, if it's been 10 hours, then you are good to go right now, most likely. But
I'm afraid to feel the withdrawals though. Do I really have to be in active withdrawal to start the Suboxone?
you want to be in active
I
withdrawal.
do, yeah.
Because if you're not in active withdrawal, so the way that Suboxone works is, Suboxone has what we call a high affinity for the opioid receptor. That means the opioid receptor likes this medicine more than it likes other medicine. So you can think of it as being sticky at the receptor. But it's not fully active like oxycodone or heroin is. So you're not going to feel high from buprenorphine, and the difference in between the highs is enough to make you feel like you're in withdrawal. So in a sense, it's almost like Narcaning yourself. If you go from having a fully occupied set of opioid receptors to introducing buprenorphine, which will win in a fight. It will kick off the heroin, the oxycodone. It will knock it off the receptor. And that, heading down that gradient is going to make you feel like you're in withdrawal. And it's going to happen.
The PRN meds you're giving me to make me feel better, I guess, if that happens.
Absolutely. So
when do I see you again though with that app? When do I have to see you again?
I'm going to give you my phone number, and then I'm going to see you tomorrow for day 2. And based on how much you needed at home, that's what we're going to do to choose what the dose will be on day 2.
How long does it usually take to stabilize me with at-home inductions? Do I have to see you every day?
So for most people are actually feeling pretty good on day 3. Most people have found their dose within the first week, or by the end of the first week. Suboxone often works a little different than methadone. Methadone can be, people know when they're in opioid withdrawal on methadone.
Do I have to get EKGs with a Suboxone or no? You have to do that.
Yeah, our policy here is that we're going to get an annual EKG on every one of our patients, regardless. For the vast majority of people, this is not going to be an issue. But getting an EKG only takes 2 minutes. So I don't think it should be that big of a deal. But yeah, I think that for Suboxone, the thing I'm going to ask you every time I talk to you is I'm going to ask you mostly about your cravings. And we'll titrate based on cravings just as much as we are based on withdrawal symptoms. So if you're having dreams about using drugs, if you're thinking about it a lot, these are all reasons you might need a higher dose.
All right, thanks, Rob. All right, so technically, you can within like a week, pretty much, you can get them stabilized on a good maintenance dose.
Yeah, which is great. It's also I can't just like throw a cup full of methadone at someone because they'll, they can overdose. Especially because you have like methadone, one dose builds on the next one because of the half-life.
So do
But
you try to like bridge someone on methadone, then you go to Suboxone, or is that what
yeah,
you do? And then keep them
that's
on Naltrexone if they can get off it?
yeah, that's the biggest pain in the butt that there is. But
What's
there's
harder, going from methadone to Suboxone or going from Suboxone off to Naltrexone? What's
going
harder?
from methadone to Suboxone is hard.
Really?
I've I don't know anyone who wants naltrexone ever.
Hmm.
So I don't know. I have never actually had a patient who wanted it. Except for I mean, I don't know. I guess that's not necessarily true. I have like some patients who strictly have alcohol dependence, but that's I mostly do opioids. Um, but yeah, I mean, going from methadone to Suboxone, the best way to do it is like a new school way that I'm not allowed to yet, which is like the microdosing techniques. And it's just like, I don't know, the law is like Oasis is catching up with this stuff, but the way to do that is you kind of sneak the buprenorphine in. You start with a 0.5 milligram uh, as a one-time dose on day one, then a 0.5 milligram BID on day two. Then I forget. I have a couple of them written down, but I never do it. So, but that seems to work. There's like actually really good studies. I saw one study where they took patients. Most people will tell you to bring their methadone dose down to 50 before you try to switch them to Suboxone. But I saw one study that did it from I forget how many days they did it, but they maintained you on 100 milligrams of methadone the entire time while they microdosed, and it was successful. I think I have that study somewhere, so I can send it.
Yeah, send it to me.
Yeah.
All right, thanks, Rob. Appreciate your insight, man. Thank you. This is
Yeah,
my specialty in mind, so you probably have more to share than I do. But all right, so these are the three receptors, right? So the U is actually starts for the mu, right? Activation, analgesia, we know that, right? That's what it's used for, pain relief. It can cause euphoria, it can cause sedation, physical dependence, tolerance, right? Changes smooth muscle tone. So usually it'll cause constipation, right? People have a hard time using. Obviously withdrawal. So it's up to you how you want to memorize this. Know what intoxication looks like, and then obviously withdrawal will be the opposite, right? Or you can go the other way. I prefer to memorize intoxication and then withdrawal is just the opposite. Or if you want to do the other way around, it's really up to you. All right. So you have delta, right, which is anti-anxiety, antidepressant properties. All right. And you also have kappa, all right, which, that causes, so all three are going to be innervated, all right? That's why you have all those side effects. Sometimes I use naltrexone for self-injurious behaviors too, especially in children who have lower, like on the spectrum or, have issues with self-harming because, the principle is that if they're self-harming because there's kind of a link between pleasure and pain and it feels good for them. So when you take that away, it's not reinforcing, right? Someone might bite their finger or might bite their arm or might pull their hair, trichotillomania. So I usually use naltrexone for that, right? This is the cows. This is how we assess for opioid withdrawal, right? So obviously you would score it based on that, and based on a score, I'm not going to test you guys on, patient has 23. What is that? Mild, moderate, or severe? That doesn't matter to me, all right? Because you're going to be using this chart anyway. But I do want you to understand, giving someone a partial agonist if they have full opioids on the receptor is going to do what, right? Robert mentioned that. High affinity, it's going to bounce it off. You're going to put someone in something called PW, which stands for precipitated withdrawal, right? Which is usually a withdrawal that's worse than if they stop using it, right? They're going to have like symptoms that are really bad, worse. You don't want to put someone in precipitated withdrawal. They're going to hate you, all right? I've done it by accident a few times early on in my career. Don't do it, all right? They're gonna shit their pants and you have to clean up your office. All right, so cows. Cows is for opioids. All right, any questions? This chart is pretty self-explanatory. These are the medications used for opioid withdrawal, right? We talked about methadone, which is a long half-life, right? Then you have naltrexone, which is a long-acting opioid antagonist. You have buprenorphine. You have buprenorphine naloxone, which is also called Suboxone. Oh, lofexidine. Rob, that's what I was talking about. Lofexidine is a alpha-2 agonist. Have you looked it up?
So I think that's expensive, right? I
It is
clonidine
expensive. Yeah, it's
clonidine
expensive.
is cheap. I
Yeah.
only use clonidine.
Yeah. It's clonidine that doesn't hit as hard, so it doesn't cause the rebound hypertension if they stop, and the sedation is not as bad. Yeah. Right. What's the difference in naltrexone and naloxone? Like I said, just know the naloxone is short acting, right? It's a rescue drug. Naltrexone is a maintenance drug. Signs and symptoms of opioid intoxication, right? Choose one, and then obviously the opposite. It's interesting, Rob. Do you know why people yawn when they're having withdrawal? No one's ever given me like a good answer. I've asked different doctors about it, but no one really knows. Why is
I
yawning
actually
so important? Huh?
I don't know, but it's like one of my favorite cows items, just
Yeah,
because it's so objective, just like that, and people, like people can BS you about a lot of stuff, but
yeah,
if someone's yawning every 3 minutes, you're gonna notice it. And
yeah.
the pupils, if they're on some kind of other drug, then maybe they're dilated. But it's like my favorite for Suboxone induction. That's like the first thing I look at is everybody's eyes.
Interesting.
Yeah, and then the yawning, of course. Yeah.
These are just brain scans, understanding. Well, this is about alcohol, but alcohol is probably one of the most dangerous substances we have because a lot of people use it, right? Make sure you screen for it, especially if someone has comorbid substance use disorder, if they're drinking wine or drinking alcohol. This was very big during COVID, right? And what happens if someone's not doing better on your treatment, right? They could have depression, they could be with you for anxiety, and you're not responding. Go back and say, hey, you drink alcohol. Because if you don't treat that, you're not going to get the full clinical picture. They're not going to get a full response. All right. Things I usually look for when someone's not responding to treatment, is there a comorbid substance use that I'm missing, right? Are they using something to self-medicate and I'm missing that? Or are they sleeping enough, right? If sometimes people have chronic insomnia, it can lead to a lot of stuff, right? So if you treat the insomnia, is there interpersonal stuff that's happening? Are they going to therapy, right? Wernicke's encephalopathy, this has to do with alcohol use disorder, but we're going to review this again next week, but just understand, right? Why is thiamine so important in the body? Do you guys know? What is thiamine involved in? Metabolism of what?
ATP of energy. It helps
Yeah,
you
it is.
move.
Yeah, glucose, right? It's involved in glucose metabolism, right? So what happens if someone has a thiamine deficiency and you give them glucose, there's going to be no thiamine for the body to work, right? That pathway is going to be impaired and it's going to start causing brain damage technically, right? It's going to break down, right? So Wernicke's encephalopathy, change the mental status, ophthalmoplegia, which I've seen numerous times in the hospital. I used to work in the ERC PEP, right? They follow your finger and one eye will move and the other eye will not move, right? Another thing to know clinically is that if you're giving someone benzos and they have lateral nystagmus, that means you're going too fast or too high with the benzos, right? When do we usually give people benzos? Besides to taper them off alcohol, if they have catatonia, right? So if someone has catatonia, you're giving them Ativan and you want to get them out of the catatonic state, but you're going too fast, you're going too high, they're going to have lateral nystagmus, right? So maybe go a little bit slower if you have to. Cerebral dysfunction, they're going to be falling, risk of falls, it's going to be imbalance, right? Now, the reason why people are at risk for thiamine deficiencies when they're drinking alcohol, they're not actually eating, right? They're just getting alcohol and they're not getting full nutritious diet, right? Other risk factors, chronic alcoholism, malignancy, chronic hyperemesis, right? Besides hyperemesis of pregnancy, why are people having hyperemesis now? What's causing it? Which I've been seeing.
Cannabis.
Huh?
It's like the cannabis hyper.
Cannabis. Yeah, it's really bad. Yeah. From cannabis use, so they vomit nonstop, right? Anorexia nervosa. Again, if you're working in adolescent psych or pediatric psych, that's something that you need to rule out. All right. It's one of those something. There's two things called, right? There's a misdiagnosis, which is MIS, right? Which you're labeling something, but it's totally off, right? You think it's bipolar disorder, but it's actually borderline personality disorder, right? You're treating the wrong disorder. The patient's not getting better. Or you have a MIST, MISSED diagnosis, right? They have a comorbid opioid use disorder and you're treating them only for depression and you're not treating that at all. You missed it. Or they have alcohol use disorder and you're treating them only for depression, right? Someone has anorexia nervosa and you're treating them for anxiety or depression. If you're not treating that eating disorder, it's not going to get better. And what happens if someone has anorexia nervosa and you give them SSRIs and their BMI keeps dropping? What happens? What could it cause? It can actually cause brain damage also. It can cause damage to the brain as well. All right. A lot of times I'll do Chem 20s just to make sure the sodium is low. Remember, hyponatremia, low sodium, can cause seizures, right? Another thing, hyponatremia. A kid has anorexia nervosa. You missed the diagnosis, right? Now they're having ADHD, but the ADHD is actually they're having absence seizures from the hyponatremia because they're not eating, and you missed that. Now you're giving them stimulants, you think it's ADHD, and it's actually making it worse. See what I'm saying? See how all these things can happen with a patient with a clinical picture, right? Especially when you're working adolescent psych. You're treating one thing and it's making something else worse. If the clinical picture is complicated, I would go back and say, hey, let me see. Is it an organic? Is there electrolyte imbalance, right? You should be ordering labs. Look at the labs. See how it's trending. Why is sodium dropping from month to month? Something's happening, all right? And every time you do their height and weight, their weight is dropping for whatever reason, right? What's a question you can ask somebody to rule out anorexia nervosa? What can you say to them? Do you force yourself to vomit after you eat? They're probably gonna say no. What can you say? What can you ask them? There's different ways, but I'm just curious. Well, how would you ask? How would you try to rule out anorexia nervosa? What could you ask somebody?
Would you ask them if they were happy with their appearance?
You could, yeah, perfect, yeah. When you look in the mirror, what do you see?
Hmm.
You look in the mirror, what do you see? I don't want to talk about it. What do you mean you don't want to talk about it? And then if they say that, then you explore it. Okay, then you can speak to the therapist. There's something off about them, right? Try to explore body image, see if there's an issue. Or then you find out they're exercising a lot, or they're restricting, or they're using what do you call those things to make you use the bathroom? Diuretics, right? So these are things that you should look out for. Okay, obviously B12, B1 thiamine deficiency, you would give them thiamine, all right? You would replenish it. Because eventually Wernicke's leads to Korsakoff's. Korsakoff's is irreversible. Wernicke's is reversible, right? You treat it early enough, you give them the thiamine back, it's reversible. If you wait too long, you become Korsakoff psychosis, all right? For alcohol use, we use the Siwa, all right? You know, you use naltrexone also to help with cravings. Remember, it's opioid driven, same concept, right? Now, there's something called DIP, disulfiram-induced psychosis. So be careful with that. All right. If someone has a history of psychosis, there's a family history of schizophrenia or any type of psychotic episode, I would be careful with disulfiram. I've talked about this in my other lectures. I don't know if you guys watched it, but why? What does disulfiram inhibit? It inhibits aldehyde dehydrogenase, right? Which makes people feel sick, which is why they can't metabolize alcohol appropriately and they feel really bad, right? Or it also affects something else. Dopamine beta hydroxylase, right? So what happens when you inhibit that? You actually have an increase in dopamine, right? Because what creates norepinephrine? Norepinephrine actually gets converted to dopamine, right? Dopamine gets converted to norepinephrine, I'm sorry. When you stop that pathway, you're going to have a buildup of dopamine. If someone has the genetic predisposition for that, they're going to become psychotic, all right? Sometimes you stop the disulfiram and it goes away, but sometimes they can become chronically psychotic. You awoken those genes already, and now they have their first break of schizophrenia, right? Or psychosis or whatever. This is something that happens a lot too, right? Inhalants, very big with kids, right? And the molecule is called toluene. Toluene. They sniff it, they inhale it, they get it from paint, nail polish, and kids get high off it. So that could be also very dangerous. So make sure you can ask the parents when you check the rooms, you ever find like odd stuff like a lot of paint or a lot of like, glue, that they could be sniffing it. Inhalant use disorder. Very popular now with kids. And it can also lead to psychosis, right? PET scan of dopamine receptors. The important thing about this is that, look at the healthy person and look at the 14-month abstinence. It took about 14 months for the brain to go back to the way it was. So if patients losing hope and saying, hey, I've been clean for 6 months and I'm still having this chronic dysphoria, I wanted to go back to using meth, right? What do you tell them? Well, there's some studies out there that show that it could take over a year for your receptors to regulate again, right? So continue motivational interviewing, make sure they stay checking in with them frequently, right? There are some studies that show that maybe some partial agonists, right, like Vraylar, cariprazine, they're studying that now for stimulant use disorder, right? Because it's giving them a little bit of dopamine, just enough to help with those cravings. And then if they do try to use it, it'll be on board because the affinity with the partial agonist is stronger than the stimulant, right? Cannabis, right? It's pretty much prevalent everywhere now. So I'm just letting you know on the bottom is marijuana inhibits 3A4. So give me some 3A4 meds. What do you guys remember? What are some psych meds that are 3A4? You guys know? Give me a name or a class. Atypical antipsychotics are 3A4. Right?
Carbamazepine, the easy one.
What's another 3A4?
Like Latuda.
Two is 3A4, yeah. Benzos are 3A4.
Yeah.
Benzo 3A4. What's 2C9? That's a little bit harder. What's 2C9? Depakote is 2C9.
Fluoxetine, right?
Yeah, 2C9. Yeah. Yep. 2C19, sertraline, escitalopram, citalopram. Right? These are just some of the. You don't have to memorize it, but just have a general understanding. All right. My rule of thumb is that when you start practicing in the beginning, have one or two meds for each diagnosis and know those meds inside out. Right? If you're gonna give every patient Lexapro and Zoloft in the very beginning until you get comfortable, know what substrates metabolize it. Right? Know all of its interactions. If you're going to use even ADHD meds, right? Know the onset, know the peak, and we talked about last week, know how long it should work for, know what any drug interactions with it, whichever one you want to use, right? Pick a short-acting one, a long-acting one, intermediate one, and it's up to you, right? And you keep building your repertoire, keep going up. This is just some things you guys should know about potential consequences of long-term use of substances. Obviously, withdrawal, right? Tolerance, brain chemistry correlated with drug abuse. Um, down regulation, up regulation, that's all important to know. Signs and symptoms of opioid withdrawal, right? When someone's in withdrawal, they're going to feel dysphoric. They're going to have rebound pain. They're going to have hyperactive bowels. They might have diarrhea. Stimulant withdrawal, this is important too. If someone has a chronic dysphoria that's always happening and they're not responding to meds, find out the reason why. If they're only feeling depressed Monday to Friday, right? What's probably happening? They're probably having fun on the weekends and they're using crystal meth. Right? They're only depressed on the weekdays. So these are just little clues to figure out what's going on here. You're not just going to give them Prozac, right? Because obviously it's not going to get better. You have to figure out what's happening there, right? Identify how to treat cravings using partial agonists, using naltrexone, right? Know how to manage withdrawals, and Robert touched about it, right? So if someone's having withdrawal, they're having anxiety, an option could be clonidine, right? An option could be lofexidine. You can also use hydroxyzine, Atarax, right? If someone has comorbid ADHD, you might use clonidine too, right? Because it's also, you always try to kill multiple birds with one stone. So try to depending if it's like insomnia. If someone has insomnia and depression, you can use trazodone, right? Someone has insomnia with poor appetite and, some anxiety, maybe mirtazapine, right? So you want to try to use the clinical profile of each med and because you want to avoid polypharmacy as much as you can, all right? Really simplify the regimen. All right. Questions?
I guess mine's more of an observation, but that I imagine that that dopamine thing with the recovery time is the same for opioids. For whatever reason, people who quit methadone before 1 to 2 years have an 83% chance of relapse. And I think that's actually the number is the same for buprenorphine too. And it's just like, I guess, giving your body time to go back to the way it used to be.
Yeah, it's interesting. I know people also have that there's that book called well, people do dopamine resets. They kind of stay away from like social media, stay away from a bunch of stuff and give your brain some time to kind of go back, right? So go to nature, use some psychedelics or mushrooms. I don't know. They apparently the psychedelic trials are not going so well. Apparently they think the FDA is not going to approve it. But
Yeah,
anyone here besides Rob have experience with treating opioid use disorder or substance use disorder or anything or
I have a bunch of patients who've done ibogaine therapy in Mexico. My rich patients have gone through it.
Oh, you mean what is that called? Ayahuasca.
It's like ayahuasca, yeah.
What is it called? What was that? It was another name. You gave me another. What is it?
Ibogaine. I actually don't know the difference
Oh.
between them. But I guess there's some difference between ibogaine and ayahuasca. There's randomized controlled trials on it. It usually only helps people for like 6 months at a time, but it does really seem to work. Before for 6 months only, and then people present for readmission. But yeah, people spend like $5,000 on it. They do a hallucinogenic drug. They vomit and have diarrhea for like 3 days, and then they stop doing heroin. Yeah.
Oh.
Yeah.
It's interesting that when they make the ayahuasca, they actually make like a homemade MAOI inhibitor. Because apparently if you give them just the ayahuasca, your body eats it up and doesn't do anything. So the person, I guess the witch doctor, whoever makes it, combines it with like a MAOI type thing. So it kind of blocks your monoamine oxidase from breaking down those neurotransmitters, and that's why it kicks in. Yeah. Interesting. Street pharmacist. Yeah. Anyone have any questions with, it doesn't have to be about substance use. We can talk about it, anything that's not clear. I mean, everything ties together eventually anyway. Yeah. Oh, I'm sorry. Chairman, I know you emailed me about the Jonathan's Law thing. That's not important. I can care less about that. You guys don't need to.
Okay.
Jonathan's Law has to do with prescribing well, they might actually right now it's on pause. Rob, you know what Jonathan's Law is? You work in substance abuse. Do you know what it is? Okay.
No, I don't.
Jonathan's Law is a law that was made because someone named Jonathan died, unfortunately, because they were prescribed opioids over the phone, telehealth. So Jonathan's Law is a law that means that in order to prescribe controlled substance, you have to see the person, which is really stupid though. I feel bad for Jonathan, but this law doesn't, because you have to see the person once and then you can prescribe them controlled substances indefinitely after that. You only have to see them once in the clinic. And then you can do telehealth after that, and it's fine. What's the difference, right? If you're going to see them once or see them 3 times, does it make a difference? So they paused Jonathan's Law now because a lot of patients are stable on ADHD meds, right? And all these companies have been able to provide telehealth because of COVID. So now the question is, what is the FDA going to do about it? Because now you have, who knows, 100,000, 10,000 patients that are stable, seeing providers from far away that they were being treated for, for years now, right? Since COVID started, and they're stable on the controlled substances. Now you're forcing them to show up in person and they're going to lose access to care. I guess it's both ways. There's also the problem is there's prescribing. There was that company that the FDA is suing. What was it called? They were focused mostly on ADHD. You guys remember the name of it? I can't remember the name of it. God. They were focused on. So the funny thing is, like maybe 2 years ago, I was seeing like I would be on like social media and it would say, I think you have ADHD. Click on this to do a scale. So I clicked on it, I was curious. And then you would answer the questions and it would say, congratulations, you have ADHD. Please click on this link and we'll send you a prescription to get your stimulant. It was that easy. It was crazy. That easy. Yeah. And people would just see like, unfortunately it gave us a bad rep because a lot of those prescribers are nurse practitioners. And they actually wrote articles about nurse practitioners just sending scripts for ADHD and all these people had access to ADHD medications. Right. I can't think of the name of it, but now they shut it down. So actually, no, I think it's still open, but they're not allowed to prescribe stimulants anymore. And a lot of pharmacies don't take scripts from them. Yeah. But it's pretty sad.
Yeah, in New York, you're not allowed to prescribe buprenorphine over telehealth without like seeing someone at least once. I guess it's probably the same. It's because of Jonathan's Law, I guess.
I thought they waived that. Are you sure that they still have to see them in person once? I think it's still paused though.
Yeah, the last time I checked, I think that that was it. I was looking at a job with a telehealth company called Bicycle that does telehealth buprenorphine, and they were not hiring in New York because they said that they couldn't.
Interesting. Yeah, I haven't prescribed Suboxone or buprenorphine in years since I worked at NYU, so it's been a while. Yeah.
Yeah, but that seems crazy to me because it can be so hard to get some people just really struggle to find a provider who will write them a Suboxone script. And you can't overdose on it. So, people divert it all the time. People are just outside my clinic, people are selling it. Yeah, but so like the diversion is real, but at least it's safe.
Yeah, I mean it's harm reduction at this point, right? It's so prevalent that any way to kind of help people because I mean now they're selling Narcan over the counter, right? You can buy it anywhere.
Yeah.
Any questions?
I have a question.
Sure.
So reading the book, the chapter in Ettinger about opiates is kind of not simple, but it's much less detailed than the Stahl chapter.
Yeah.
With
No,
regard to the path, like how deep do we need to go to the Stahl level or the Ettinger level?
Stall level, obviously. Yeah, yeah. No, that book is garbage. I didn't choose that book. They just added that, but that book is garbage. I'm sorry. To be better practitioners, look at the Stahl book. That's the book that all psychiatrists use, all residents use. That's the book that I use. And that's clinically. I mean, the Ettinger book, he's a psychologist. Half the thing he wrote in that book is not even true. You know how many students last semester were like, I read this in Ettinger. Like, throw that book in the garbage. Yeah.
So Stahl level worth,
Of course.
with regard to
I mean, look at the questions I asked you guys in the midterm, right? Those were style level questions that were written by me. Yeah, those. I want you guys to become better practitioners and advance our careers. So the Ettinger is not going to advance your career. That book is garbage. Yeah, sorry. But whatever have you noticed that during the midterm, the questions that I asked are the same questions that are on my videos, right? If you watch all the videos on YouTube, I've asked those same questions to other students in other classes, right? It's really concepts. Understand the concept and fill in the gaps with other stuff. You know what I mean? Kind of like I might ask you a clinical question like I don't know. I didn't write the final yet, but patient has this symptom, right? They're yawning, they have dilated pupils, right? They're having diarrhea. What does that look like, right? That might be withdrawal from opioids, right? What could you treat them with, right? You want to treat them with a partial agonist. That would be buprenorphine, right? You want to treat them with a long half-life med. It might be methadone, right? Also know that with methadone, make sure you check liver functioning, and you also want to check EKGs, right? It can prolong QTC. A lot of our meds in psych can prolong QTC, so you always want to make sure before you with the methadone, they're on like other meds that can do it. You want to check EKG, right? It was easy for me when I was working inpatient because we had access to all that stuff. But these are things that if you have access to, check it. Sorry, I hate to be so blunt, but that Ender book was garbage. I'm sorry. I was trying to get it removed from the syllabus, but unfortunately I'm an adjunct, so I don't have that power. Hopefully Ender doesn't watch this video. I'm trying to teach you guys now early how to think as a psychopharmacologist, right? Because it's complicated. I mean, not that any other parts of medicine are not complicated, but the brain, the stakes are much higher, right? So the brain will affect everything in the body. So you might give someone anticholinergic, it's going to cause other things, right? Anticholinergic now in the summer, what's going to happen? If you put someone on a lot of anticholinergics, what are they prone to in the summertime? Burning, right? Hyperthermia, because they're not able to sweat because you're stopping their sweat glands. So they're going to be prone to heat strokes. So people on psychiatric medication, you have to warn them, not the weather's getting hot, you have to stay hydrated. All right. What about if someone's on lithium? Besides staying hydrated, what else do they need to do? They need to get electrolytes, right? Because you can keep drinking as much water as you want, but if you're not replenishing sodium or other electrolytes, your body's going to retain the lithium, and the lithium level is going to go up. All right. That was important. Really know how to prescribe lithium because I think that's an under-prescribed medication that's very important. And a lot of people are losing that skill because people still need that. Even though it's a cheap medication, a lot of farm reps will talk down about it. It's a life-changing medication. It's the only medication that we have that reduces suicides, right? It's broad spectrum in that you can use it in MDD, you can use it in mania, you can use it in bipolar depression, right? It doesn't cause as much weight gain as the other medications like Depakote or olanzapine that we use for mania. So it's a very good medication as long as you're able to prescribe it appropriately for the right patient and you monitor it. Right? I know people don't want to use it because they're monitoring, but once someone's stable on lithium, you really only have to do blood levels like once a year, every 6 months if even. As long as there's no changes in their, in their diet or any changes in their lifestyle. Like if someone wants to become a long distance runner all of a sudden, I'll probably check their lithium just to kind of see how it is while they're on the training regimen. But after that, we can go back to the same dose. All right. The complex cases are the ones that have like mood disorder with substance use disorder, right? I'm going to touch on it a little bit now because I think you guys are pretty high level and you guys will appreciate it. Diagnostic hierarchy. What is that? What do you think it means? Diagnostic hierarchy.
what do you need to treat first?
Very good, right? And what do you think? You need to treat the diagnosis that kind of encompasses the most stuff, right? So usually the ones that are on the very top would be bipolar disorder, right? Bipolar spectrum, because it can cause many different symptoms, right? Or schizophrenia causes many different symptoms. But above that, which is even above that, is substance use, right? Or trauma. So first thing you want to do is see if there's trauma involved, right? Have you ever been abused physically, sexually, verbally by them? No. Okay, perfect. Are you using any substances? Right? Because if you don't rule that out and you start going down, it's kind of like ADHD should be the last thing that you treat. Why? Because the stakes are too high. You just think it's ADHD and you give them a stimulant too easy, and you can precipitate psychosis, right? You can precipitate mania. You want to make sure that, the inattention is not due to an untreated mood disorder. Like you could have inattention when you're depressed. You can have inattention when you're manic. You can have inattention when you're psychotic. So you want to go that way. Because if not, then it gets very confusing. So there has to be a way that you kind of put things in a step-by-step manner that makes sense. It also makes sense to the patient when you tell the patient, hey, I came here for ADHD, Rob, to your office. Why are you telling me to stop my opioid use disorder? I came here to see you for ADHD. So you have to educate me. Well, if you're mixing stimulants with this, things could get a little messy.
Maintenance, Matt.
Hi, Bintu. I just gave the secret I gave the cure to schizophrenia. You missed it. Now I'm not gonna talk about it anymore.
Hi.
There was a group of students that from PACE, so it was like the last semester, and I was supposed to talk to them. And I said, okay, this is the most important thing I'm gonna tell you guys now. And I was very serious. I said, life is a simulation. The medications are all placebo. And I was like, you just wasted your 3 years. And I walked out. That's partially true, though. A lot of our meds do have a very strong placebo effect. So you just have to be careful with, your prescribing, right? Just understand if someone feels better after like 2 days, that's probably placebo effect. Doesn't mean that the med's not going to benefit them, but you have to let them know, hey, after a while, placebo effect does go away, but you have to give time for the meds to work. Yeah, placebo is not a bad thing. You just have to leverage it in the right way to give the chance for your meds to actually work. And there's also nocebo. What's nocebo? You guys heard of that term before? What's a nocebo effect? It's the opposite of placebo. People have side effects from meds, but it's actually not from the medication, right? They go online and they start looking at stuff, this is going to cause this and this. And before they even put the medication in their mouth, they're already having diarrhea, right? Or they're already having sexual dysfunction before they take Prozac, right? You have to tell them, you're going to read stuff online, but, some of it's true, some of it might not be. Just know that legally, drug companies have to put every side effect, right? If someone takes Prozac and walks out of the house and gets hit by a car, is that a side effect? Right? It's not, but it's linked to it, so they're going to put that in there, right? I'm being extreme about it, but they have to put everything. So if you look at all the meds, every side effect has been listed there. It doesn't necessarily mean that it's actually the medication causing it.
Yeah, I always, when I prescribe someone a statin, I'm always like of a mixed mind whether I ever talk about myalgia, because there's been studies that show people who are told about the side effect experience more of it. And I'd rather you just take your rosuvastatin. So I like almost don't even want to say it.
I mean, that's the thing, right? That's why it's important to develop a relationship with your patient first before you start dropping bombs of side effects, right? Like before I prescribe someone clozapine and I talk about how it's going to shut down your immune system and possibly kill you, I want to make sure that you trust me. And then, because if they trust you, they know that you wouldn't prescribe a med unless you knew that the benefits would outweigh the risks, right? So it kind of takes time to develop that relationship. Sometimes it's better, like to not. I think the mistake some people make is that when they're anxious in the beginning, when they're first practicing, is they want to get a script right away, right? No one tells you that when you see a patient for that first appointment, you have to write a script right away, right? And you even tell them that I'm sorry, because some patients will actually say, that's it, the appointment's over, you're not going to give me a prescription, right? And you tell them, like, look, I know you were expecting it, but I think that in order for me to get a better diagnosis, right? If it's not life and death, let me meet with you a few more times, because I don't believe in prescribing meds, prematurely. Let's talk about it, and I hope you respect that, because I don't want you to have side effects or take a medication unless you really need it. Most patients say, okay, I understand that. Because a lot of times you think, oh man, I'm charging their insurance. I should write them a script for something, right? And they're going in there saying, oh my God, I didn't get my money's worth because Rob didn't write me a script for, Xanax 10 milligrams, right? But also at the same time, you have to be like, you have to be confident in your ability that don't wait. Like I had a student who was first practicing. I hired him actually. Hopefully he's not watching this video, but I was joking around because sometimes he would say, "Oh, why don't you try Benadryl, like over the counter, like for anxiety?" I'm like, "Look, you can't just keep recommending over the counter stuff because you're afraid. Just prescribe them something, you know." And I was making a joke. I'm like, "Don't tell them to like lick the lithium and put it back in the capsule for the first couple of days, and then after the week, you can take one bite and then put the other half in, right? You have to trust that your skills as a practitioner are right, your intuition is right, and the patient's going to take the meds. They're going to be okay. For the most part, I mean, most of the psych meds, right? They have a therapeutic index to kill you of 10 times. That means that whatever the FDA daily dosage, you times that by 10, and that's how much that's fatal, right? Besides meds like lithium, obviously, or clozapine that have a narrow therapeutic index, I've seen people overdose on, the whole bottle of Prozac. They're fine. They take them to the hospital, but most of our psych meds are pretty safe, barely enough. Any questions? So definitely no opioids withdrawal. Next week is for alcohol, so that's why I just touched on it quickly today, but we're gonna go in more detail about that next week. And we'll go back to opioids also. Why does an alpha-2 agonist help with symptoms of withdrawal? Why do you think? What does an alpha-2 agonist do? What is alpha-2? What is it? What is alpha-2 presynaptically, to be more specific? It's a autoreceptor, right? An autoreceptor helps regulate the neurotransmitters, right? So what happens is if you give someone an alpha-2 agonist and hits the autoreceptor, is it going to increase the release of norepinephrine or decrease the release of norepinephrine? What do you think? What do you think, Bintu? I'm putting you on the spot. If someone's having withdrawal from opioids, they're going to have tachycardia and they're going to be anxious, right? So what's an alpha-2 agonist going to do? Why do I want to increase norepinephrine? Why do you think? So, you don't know?
It will decrease the
It will,
withdrawal
okay, it will.
symptoms.
Okay, you tell me, how does an alpha-2 agonist decrease norepinephrine? Where's alpha-2 located? Presynaptically and postsynaptically, right? But it's going to work presynaptically too. So when you give someone clonidine, it's going to decrease norepinephrine release because when it hits those autoreceptors of alpha-2, it's going to decrease, right? And it's going to decrease the hyperarousal. Understand? Just because you hear alpha-2 agonist doesn't necessarily mean that it's going to cause, hyperactivity, right? Or make someone feel sympathetically active. It does increase norepinephrine though, a little bit. That's why sometimes in the beginning they might get, but that's why it also helps with ADHD, right? Because it helps tune norepinephrine, right? It's kind of like blocking norepinephrine, but it's also giving a little bit by itself. That's how it works in the frontal lobe, in the dorsolateral prefrontal cortex. You also find alpha-2 on serotonin receptors too. That's why we call them heteroreceptors. Because just because something is a dopamine neuron or a serotonin neuron, there's different connections there too. There's also different receptors from different neurotransmitters. If it wasn't confusing enough for you guys. So an alpha-2 is called a heteroreceptor because you'll have alpha-2 presynaptically on norepinephrine receptors, and you also have alpha-2 autoreceptors on serotonin receptors also. That's why if you give someone alpha-2 antagonists, right, like mirtazapine, it increases serotonin and norepinephrine at the same time. Why does opioids cause respiratory depression? I don't know, Rob, do you know the reason? What's the pathophysiology of how it causes respiratory depression?
I knew this better when I worked in the ICU, actually. I don't even think about it anymore now. It's just, and also I used to get pimped in the ICU. I don't get pimped anymore. Yeah, I don't know. I don't remember.
So your brainstem has receptors on there, right? That kind of help regulate how much CO2 builds up. right? So what happens when a certain amount of CO2 builds up? What happens? Your body's forced to breathe, right? To exchange, bring in oxygen and exhale CO2. What happens is those receptors based on the opioids stop working. So those sensing receptors don't work anymore. So your body keeps building up CO2, and slowly you suffocate, right? Carbon dioxide builds up in your body, right? And you stop breathing. Because that reflex, usually it's a reflex, right? CO2 builds up to a certain percentage and your body exhales, right? When you take benzos and you take opioids, those sensing neurons don't work anymore, and you just don't breathe, right? It's like you have to force yourself. Normally, breathing is autonomic, right? You can just breathe normally. So it's rare, but also like you mentioned, opioid withdrawal can also cause some psychosis, right? Due to the downregulation, right? The compensation. This person did they have a history of schizophrenia already that you know? They did? Yeah.
Yeah, he did. And he'd been through, just looking through his chart, he'd been treated with a whole array of different things. But yeah, the last Lincoln discharged him on quetiapine when he was previously on olanzapine. So I think
How
that's,
high how high timing? It must have been
I mean,
must have
look,
been like in the 500, 600, I would think.
yeah, he told me 300 in the morning and 200 at night, but I actually have his discharge paperwork right here, so I'm just gonna look at it. Let's see. Yeah, well, he had it backwards. There's 200 in the morning, 300 at night, which makes sense.
100.
And then they're giving him 100 of Benadryl nightly. They were just trying to zonk him, I think. But I think he was screwing it up and taking the Benadryl and the 300 quetiapine in the morning. So he was like falling asleep, which was really useful when I was trying to get him to wait for the ambulance, but I couldn't keep him asleep for the whole time.
So what's your plan to switch him to Invega? Why Invega though?
I am not actually sure. Oh yeah, because he's non-compliant.
Oh.
That's why. We're thinking because he comes here for methadone, if we can get him, he's been our patient for a long time. And the nice thing about there are a lot of things about methadone that are annoying for the patients, but for clinicians, it gives you like a really unusual amount of control over your patients. We see these people all the time. And I give this guy a lot of latitude. He gets a take-home bottle every day for a split dose. But we still see him 5 days a week. So we'll be able to, and he's dependent on this medicine. So even if we switch him to a once a month schedule, if he's doing really well in his recovery, he only comes every 28 days. That will be the day we can give him an injectable antipsychotic too, and keep him, keep him living a normal life. Yeah.
Would you stay at a shelter or?
No, he's got an apartment. He was actually doing really well for a lot of this year, and I was surprised. Before I had him on a split dose, he was a hot mess. He could, but he was a fast metabolizer of methadone. He'd go into withdrawal every day, and he would use every day, and it was really difficult to get him to stop using cocaine. That was like the hardest part, which also could have been one of the reasons why he's such a fast metabolizer, honestly. But sometimes it's hard to parse that, like what
Fast metabolizer, what substrate? What metabolizes methadone?
3A4.
And there's another one.
2D6.
2B6. B isn't, yeah, 2B6.
Okay. Yeah, I mean, I actually had a patient who I forget what I had a patient who was started on mirabegron, which is an alpha-2 agonist that's used. It's like an extremely expensive ditropan, almost.
Yeah, I never heard of that one before. Yeah. What is it
Yeah.
called? What do you call it?
Mirabegron. So it's used for not is it urinary retention or BPH? I forget what it's for. But the patient was not responsive to ditropan or oxybutynin, and they started him on the mirabegron, which worked really well. I had to double this guy's methadone dose in the course of a week. It was unbelievable.
It was an inducer? It was inducing?
Yeah, that was, and I think, I don't know if it was also just like his metabolism working faster with a sympathetic drug, but let's see. Yeah, so it induces. Oh no, I'm sorry. Yeah, I'm sorry. I'm reading PubMed. Uh, Actually, it's a big inhibitor according to this PubMed article. But yeah, that was like one of the most dramatic uh, um, drug-drug interactions I've ever seen. Where this guy had been stable for 6 months, not using, got started on this medicine, and all of a sudden he needs his methadone dose from 100 to 200 in the course of like 6 or 7 days. Um, yeah, which normally you never go that fast because methadone's half-life is like super variable, but you can expect it to be, when you do a peak and trough, you can expect 24 hours. But for most, but really 48 to 72 hours is like people will fall somewhere in the middle there. So if you increase the dose every day, these doses are stacking on top of each other, and it starts to get really dicey really fast.
The question for the class, except Rob, if someone comes in is on methadone and now they're complaining of MDD depression, which antidepressant might you stay away from? Which SSRI might you not prescribe? Or actually, remember, which SSRI might interact with methadone? That's even more direct question. Why? Which might cause big effing problems with methadone?
Fluoxetine.
Fluoxetine, very good, right? Fluoxetine, right? It's because it's an inhibitor. It inhibits a lot of 3, 4. I think 2B6, 2D6 also inhibits. Yeah, so that'll increase the methadone levels, right? So they might have more sedation, right? I mean, maybe the question would be not to do it because they might have a history of doing well in Prozac, but just be aware that you might have to make some adjustments on the methadone possibly. What do you think about that? Have you ever seen interactions with Prozac and methadone?
No, but most of my patients aren't on Prozac. And most of my patients can have like a very high opioid tolerance. But that's, when I first started working at Bellevue, we didn't have what's it called? Like barcode scanners for administering meds. And, Bellevue killed one person with methadone and put another in a coma. Yeah, and I guess I have to be careful with HIPAA because this is going YouTube, so I'm not going to say that much about it. But
Hypothetically, you were kidding. You were just kidding.
yeah, but someone who's opioid naive, it's a super dangerous drug, especially at the doses that we give people who are opioid users. Like your average person before fentanyl got 80 to 120 milligrams of methadone. Now it's not uncommon to get 250.
I used to work inpatient in NYU. Sometimes the patients would come and they would be like, "Oh yeah, I'm stable on 80 milligrams of methadone," but unless you can confirm it, you have to like call the clinic, and they don't answer. I'm like, "I'm sorry, I can only put you on 30," and they would be like so pissed.
Yeah, yeah. Oasis just raised it. It's like the quiet thing, but Oasis just raised it to 50 milligrams. They haven't rolled it out, and it's like in like a lot of publications. And probably nothing will change in the hospitals because the federal guidelines from SAMHSA still say 30 milligrams.
Yeah, no, I feel so bad. I'm like, I'm sorry, I can't give you more until I confirm it, and then we get so mad at me. Yeah.
People leave AMA all the time because of that. They'd rather just go get high than like sit around and suffer. Being in a hospital is painful enough, just sitting around doing nothing,
Speaking about fluoxetine, sometimes I use that as a technique. If a patient is on like Abilify for psychosis and they don't want to go up in the Abilify because they're paranoid, but for some reason they have like anxiety or maybe depression, I say, let's add Prozac. In my mind, I know the Prozac is going to help with their depression, their anxiety, and increase their Abilify at the same time. So that's a technique you guys could use too, right? Add Prozac if you want to increase with med, but they're giving you pushback. Another technique I use too, if someone's on lithium, right, and they're on BID dosing, they're on like 600 milligrams of lithium or 900, and then it's twice a day or it's like 600 at night and 300 in the morning. Remember, I told you guys on lithium, you want to dose lithium all at bedtime, right? Because it's safer for the kidneys. But at the same time, when you dose it all at bedtime, it increases the lithium level by like 25% or 20%. So what you can do is technically, you can say, okay, you don't want to increase the lithium. Let's just move it all at bedtime. Most patients will say yes, right? Oh, you mean I don't have to take it in the morning? No, it's the same thing. you can move it all at bedtime, and it'll increase lithium level by like maybe 0.25 or 0.3. So you can get it a little bit higher, and they'll have better symptoms, remission. It's a technique also. That's why understanding pharmacokinetics and pharmacodynamics could really help you with your job. That's why I joke around. And to be effective in psychiatry, you have to be like MacGyver. Remember that show MacGyver back in the day? He had like a rubber band and a pencil, and he would like blow up a room somehow. They would lock him in a room, and he could make things out of different things. That's because our meds are very limited, so you have to learn how to work with. Sometimes pharmacokinetics could be to your advantage, right? Oh, you don't want to increase your meds? All right, just start drinking grapefruit. It'll help you with your vitamin C levels, right? And it'll increase it. Right? So, sometimes you have to. Then they feel better, then you say, okay, stop the grapefruit, I'll just increase your dose. You don't have to drink grapefruit every day. Chamomile tea or whatever, right? Inhibitors. Every question I put in your exam were practical, right? I think the final is going to be all practicals. I don't think I'm going to put a lot of like brain stuff because that's not really important. It's going to be more like a patient has this complaint, what med would you prescribe? Why? Right? That's more practical. Like I said, I want the test to be a learning experience for you guys too. And I want you, when you take the test, you learn something and you feel like, oh, wow, I don't want you to take a test and feel terrible, right? That if that's the way you felt, then I'm sorry, but that I wasn't doing my job. I want you to take a test. That's why a lot of the questions had hints on it, right? The answers had hints. It said, whatever, balance it out by smoking cigarettes, right? Balancing it out by drinking coffee, because you can go back and you learn that concept. So I really want the test to help you guys learn better concepts. I'm not trying to fail anybody here. All right. I'm not a jerk. The point is to understand it so that when you guys move on. Anyone you have clinical placements already for next semester or no? You guys did you get your clinical side? Yeah. Anyone here not have a clinical side? Anyone here doing child psychiatry? No, only adults. Any other questions? Because if not, then we'll end early today. But you can always reach out to me if you have any other questions. We're gonna review this again next week, and then we'll review. We'll definitely do a review before the final, so you guys are ready. All right. Okay. No questions. Thank you very much, everybody. Enjoy your weekend.
Actually,
Yeah.
can you talk a little bit more? You were saying using naltrexone for self-harm.
Yes.
But how common is that? I didn't know.
Yeah, we use it a lot, man. Child psych, when kids have history of like headbanging, skin picking, pulling hair, plucking, trichotillomania, biting, we use naltrexone. Yeah.
Yeah,
So
does it?
alpha-2 agonists and naltrexone are the meds that we use. Yeah. To help with impulse control, and also stop the rewarding of the behavior. Yeah.
Yeah. So I was wondering, like, would that work in autism when you have these like?
Yeah.
Okay. Yeah.
Good.
Because like I know that a lot of times, like biting classmates, biting themselves, is like a huge problem, and
Obviously it's off label, but with evidence, right?
Yeah.
Off label with evidence. Yeah. 50 milligrams I usually use a day.
Cool. That's really interesting.
But just know that long-term naltrexone use can also cause a chronic dysphoria. I'm sure you know about that, right? People who use alcohol. So people who use alcohol withdrawal, it's hard to tell. It's controversial. Is it the long-term naltrexone use that's causing to be chronic dysphoric, or is it something called PAUSE? Have you heard of PAUSE before? Protracted alcohol withdrawal syndrome, which people have used alcohol for a very long time. It could be just that their neurons have adapted to using alcohol for so long that they have a chronic dysphoria. And the only way to kind of help that dysphoria, unfortunately, ironically, is to drink alcohol again. Right? But then they're back to the way they were before, right? And you just have to teach them about that. So unfortunately, there is, if you look up PAUSE, protracted alcohol withdrawal syndrome, and also naltrexone is known to cause chronic dysphoria, right? Which makes sense because you're chronically blocking opioid receptors, which gives you euphoria. If you're chronically blocking that, you might have dysphoria, right? But it's a risk benefits thing, right? If the naltrexone is stopping you from going back on opioids, you might have to stay on it, right? Unfortunately. So of course, that's why we get paid the big bucks, because you have to make the decisions or not when to stop things or continue it, right? Any other questions? No. All right. Thank you very much, everybody. Yep. Yes.
Wait,
Question? Yes.
Just about the class stuff. So next Friday, the 5th is our last lecture then, right? Because the final is the following Thursday, the 11th. So we have one more together.
Yeah.
And we'll do alcohol and kind of review
we'll
this.
do alcohol next week, and we'll do a review for the final.
Okay.
All right, and just come with questions and we'll talk about it. All right.
Cool. Thank you.
You're welcome. Thank you very much, everybody. Have a good weekend.
Thank you.